The one that's been FDA approved is much more expensive. Okay, so it's really up to your doctor. You don't get to go in and say, all right, Ms. Peterson, Dr. Peterson, I am having side attack. I do not want any of that sorbitol in there. That's just not, but I just want you guys, again, to know the difference. Now, you can remove the suppository or the pill, depending on how dissolved it is, but it doesn't stop the effects. Once things are kind of going with it, that it does not, removal does not stop the effects of it, which is good, right? That's not our intention. But you can't say, wait, don't want that in there, and then have it stop. It just doesn't happen that way. So again, when is it used? It's used when the cervix is minimally dilated or not at all, when labor needs to get going because we have a health condition, because we're past 40 weeks, because the baby is, the placenta doesn't look like it's doing much anymore, baby's not tolerating much. Again, at one of those later tests, if they're concerned, what they're going to do is what's called a non-stress test. Now about a quarter to a third people have to go in and do a non-stress test if they're past their due date, and sometimes even before. And a non-stress test is basically where they just attempt to measure the baby's movement, heart rate, you get on the monitor in the OB, and they just check in to see if everything's okay. The other thing that they do like that is check to see how much fluid you have surrounding the baby. Because as we talked about, not only does the amniotic fluid protect the baby, but more importantly, it protects and cushions the umbilical cord. So you want to make sure that that there's enough amniotic fluid in there. And a lot of times people come out of the stress test and they're just fine. Some people come out and they say, doctor didn't see much fluid in there, and then things have to start kind of getting going. My suggestion to you, if you are hearing the doctor say we might need to go do a non-stress test at 3 o'clock, why don't you go home and come back? Go home and drink as much water as you can, because when you are hydrated, you're more likely to have a full amniotic sac, right? It makes sense. So if you are truly low on the amniotic sac and really truly don't have a lot of fluid, even as hydrated as you are isn't going to make it look like you have more fluid in there. But if you're just dehydrated, it could appear that you don't have a lot of fluid, that you don't have a lot of fluid in there. And then we're talking an intervention that could totally have been avoided. So again, with that non-stress test, try to drink a lot of water before, because if the results come back from that and the doctors don't like it, we're again talking interventions at that point, okay? Any questions so far? So the risks and the benefits of side attack and cervidil. If I were to get side attack, I would be at a higher risk for a uterine rupture, which can be pretty dangerous. Why would I, as opposed to any of you guys? I've had C-sections. I have a scar that's already vulnerable in my uterus. So side attack can initiate a uterine rupture. Typically, people who try vaginal births after C-sections do not get side attack to get things going, or cervidil for that matter, either of those. It will not cause a uterine rupture unless you have a previous issue with your uterus, meaning like a C-section. Again, I mentioned the off-label use for the side attack, which isn't really a risk, but I do like you guys to know about that. And there's no standard dose for the side attack. And sometimes it doesn't work. Not a risk, but sort of a bummer when you get all geared up to go to the hospital and you get the medication placed and you're thinking labor is going to happen tonight and nothing happens. And we're looking 12 hours later and nothing's happened. And it can be a bummer. So sometimes it doesn't work. And again, you do not get to get the side attack and then go home. It's once you're there and it's administered, you stay at the hospital. Again, claiming that room as your own. When you walk in and you're not even in labor, because my big thing was, I don't want to walk into the hospital like I have a dentist appointment or something like that. I want to walk in labor. That's very important to me. But when you're talking, well, I guess we just have to walk in and get the side attack, and that's not the way I was expecting it, then you claim that room regardless. Again, this is not the way I was expecting it. I thought I'd come into, to the hospital in labor, and now it's sort of boring, and here I am, and that's okay too, because that's the reality with something like side attack or cervidil. A benefit of it is that it does not bring on strong contractions like Pitocin. It really just gets things going, and then once it gets things going, it leaves it and it works. So you can have a baby 5 hours later with side attack, and not a problem. You're not going to have like what happens with Pitocin, which I will talk about next. Okay, questions with side attack and cervidil. Okay, Pitocin. So this is the part of the class where I scared the people the first class I taught. And I don't mean to do that at all. And it's not scary because Pitocin can be really, really important and a really effective way of getting babies out if you want to avoid a C-section. So Pitocin is a synthetic oxytocin, and I have a really cool article that I included in here that discusses what the hormones do. And this one is the static birth, the normal, nature's hormonal blueprint for labor. It's a really cool article. I'm sorry I didn't get it to you before this class, but you'll still enjoy reading it with this knowledge. But the Pitocin it acts the same way as our body's natural oxytocin. So oxytocin is released after an orgasm, when we're feeling really lovey-dovey, when we have physical contact that we want to have, and when we're breastfeeding. So it's the love hormone, right? And so they created Pitocin to get things going for labor because that is the hormone that gets labor going. And it is used when you are stalled out in your labor and things aren't happening the way it should. Now let's say labor has already started, either through side attack or water breaking, or contractions start just by themselves, but then halfway through something's changing and you're not having contractions that are either effective or consistent. Either or, I suppose you could say. And so Pitocin will be administered at that point, or discussed. We should say discussed, because you guys still might have a choice at this point. This is why I say bring your breast pump to the hospital. And so most of the time that I see this happening is Liza will tell me her water broke at 2 o'clock this afternoon, and she needs to go to the hospital because her doctor's saying probably get in there because we need to check and monitor you. But wait, I'm not having any contractions, nothing. It's just the only indication I have it in labor is that my water broke. Bummer. I mean, it really is a bummer because what happens is the doctors consider if your water broke, you're in labor and you still have to have this baby. So you get to the hospital and again, you claim it as your own, you take that space even though this is not what you were expecting, and you start getting a dose of Pitocin. Before you even get that dose of Pitocin, I would say, can we try the breast pump for 45 minutes? Can we try a couple of these other things? Can we have some private time together to talk about and claim this room as our own and figure out how we're going to do this when this isn't really our plan? And so they say, sure, yes, yes. You get on the breast pump for 45 minutes, try to get things going. You see if the contractions are going. And if it doesn't, you have to be very honest and just say, I'm not feeling anything. And they're probably going to start talking about Pitocin pretty quick after you get there. Okay? Totally okay. Nothing to be afraid of. We talked about why that baby needs to come out because your water broke, because there's the higher risk for introducing any sort of bacteria or infections. So it's okay at that point. Another case is labor starts, things are going strong, things are great, we get to the hospital, we're 5 centimeters dilated, we're at the hospital for 4 hours, we're going good, and then all of a sudden labor and contractions sort of just totally slow down. If I'm your doula, I'm going to sit and talk about what's going on, what's causing you to clamp up, emotionally, let's just sit together. I'm going to get you guys to spend some time together. In this scenario, let's say your water hasn't broken, you can do whatever you need to do, you can have time in the room, and you try to get on the breast pump, whatever. We talk about the emotional and the physical reasons why labor is not going, and then we try to get it going again. If it doesn't, and we're stuck at 5 centimeters for 4 or 5 hours, they're going to start talking about Pitocin, okay? So that's the second scenario. The third can be if you get an epidural, and a lot of times epidurals can make us so relaxed that labor can really slow down and stop. Now the other thing that epidural can do, and I'll talk about that when we get to that point, is it can make you so relaxed that labor starts kicking up because you're not doing that I'm so afraid of the next contraction thing. Okay? So those are the ways and reasons why Pitocin is used. Some doctors will give you Pitocin if you're past your due date, but mostly they'll try with the Cytotec or Cervidil type of intervention. But if that doesn't work, then we're talking about increasing it to the next layer. So again, labor has stopped or stalled, and mom's on the clock because water is broken. That's when Pitocin is typically used.
Is it common, Molly, for labor to stall or to not even start happening? Or okay.
It can be. What I see more is people's water breaks.
Yeah.
and they're not in labor, or they're not in strong labor.
Okay.
But again, like we said, only 22% or 20% of women's water breaks. So if you're thinking about worrying, in fact, if you're gonna put that on your worry list, don't, because 20% of women's water breaks before labor, and out of that 20%, a chunk of them don't even start having contractions. That's not something to really worry about. But it can be, they use it quite often, and I'm gonna give you some reasons why maybe we just wait for a little bit for it, okay? So real quick, I'm gonna talk about how it's administered. It's administered through an IV. Now our hospital will automatically give everyone, I think what it's called, a Heplock? Heplock? Is that, yeah, okay. When they walk in. Now unless you absolutely refuse it, it's on your birth plan, you don't want any pokes or needles, and that's gonna just mess up your whole labor and delivery and your mental state. They're going to, and you fight that, then they're gonna automatically do that. The other thing, who feels strongly about not having that? Anyone in here? It's an IV, it's like a port. It's basically, they put the needle in there, they keep it, they tape it down, you move around, you're not hooked up to anything, but it's there in case it's an emergency. Now, I attended a birth with a woman who did not want it. This was her second baby, she was going no intervention, she did not want it, and her husband, who's as sweet as could be, kept telling the nurse she doesn't want it, The nurse kept saying, it's really, really good, and here are the reasons why, if we have to move to an emergency quickly, and he kept saying she doesn't want it. And so finally the nurse had to confront the woman and ask her, because the dad was trying to advocate for her, but what the nurse saw was a pushy dad who was railroading his wife's wishes. And so